هعوض المحاضره بتاعت يوم السبت، بمعنى ان انا هبتدي ادي المحاضره بتاعت يوم السبت وحته من محاضره النهارده ونكمل الاسبوع الجاي بحيث نعمل amalgamation بحيث امشيكم in sequence of events. صح. نمره واحد، انا كتاباتي ورسوماتي بسيطه، فيعني انا معتمد على الانتراكشن بيننا وبين بعض، فاللي مش شايف السبوره تتحرق مش قضيه يعني. اولا بس ده كلام فيسيولوجي، انا بهتم قوي بالفيسيولوجي علشان بدخل منه على الفارماكولوجي. فهقول لحضراتكم انا عندي هنا هو هايبوثالاموس وعندي هنا هو الانتيريور بيتيوتري. انتيريور بيتيوتري بتطلع حضراتكم وليكن مثلا عندي ادرينال كورتكس، هتكلم على اكزامبل، او ثايرويد جلاند. يبقى انا عندي الهايبوثالاموس بتطلع ريليزنج فاكتور. It will act on the anterior pituitary to stimulate the release of hormones from the anterior pituitary. Example, growth hormone. Example, ACTH, TSH, وجونادوتروفيك هرمونز وبرولاكتين. ده اللي طالع من الانتيريور بيتيوتري. ناخد اكزامبل، ال ACTH will act on the adrenal cortex. ال TSH will act on the thyroid gland. هيحصل ريليز هنا للكورتيزول وهيحصل ريليز هنا للتي 3 والتي 4. What will happen؟ حصل ريليز، what will happen؟ Negative feedback on anterior pituitary and on the hypothalamus. Short arm and long arm. يبقى في هتبقى positive feedback ما بين الانتيريور pituitary والperipheral glands. لو حصل excessive release of the hormones هيحصل negative feedback على both الانتيريور pituitary and on the hypothalamus. Okay? Let's proceed. Growth hormone. I'm going to use it for treatment of what? What's the action of growth hormone? Growth. So, impairment of growth is the main use of growth hormone. What is the impairment of growth in childhood? No. Pituitary dwarfism. Let us be very specific because we have a lot of reasons for dwarfism. The only therapeutic use for growth hormone is pituitary dwarfism. Not efficient, not sufficient information. Why? If the child is 12 years old, if he is 6 years old, if he is 3 years old, if 16 years old, no difference? Or there is a difference? There is a difference. So, this information is not sufficient to be completely right. I must add, before union of the epiphysis, because if some epiphyses are closed, united, there will be no effect of growth hormone whatsoever. That's why we must say, I'm going to use it in cases of pituitary dwarfism, but must be before union of the epiphyses. So it's a very important statement to say it. Okay. Second, what's the source of this growth hormone? From what? From where I'm going to get this growth hormone? From genetic engineering. Somatotropin. Somatotropin is obtained by genetic engineering. And it must be human in nature. I cannot use any animal preparation in relation to growth hormone. Why? Because growth hormone here is species specific. So this is the full data about using growth hormone in what disease, which type, from where the source, and the time of administration. The second hormone I'm going to talk about, TSH, thyroid stimulating hormone. It's very important to say now, what's the effect of TSH, thyroid stimulating hormone, on the thyroid gland? What is it? Now, you must remember 4 things, 4 actions. First, iodine uptake. I must know it helps in the iodine uptake. The synthesis of T3 and T4. The release and the size and vascularity of the gland. 4 actions responsible for doing in thyroid gland. First, I can't hear you. Iodide, please, iodide. Second, synthesis. Third, release. Fourth, size and vascularity. So, if I'm going to have an increased level of TSH, I'm going to see what? Goiter. What's the meaning of the word goiter? Enlargement of the size, full stop. I don't know. Goiter is an anatomical term. It is not a physiological or functional term. First of all, you can have goiter, hypothyroid. Goiter, euthyroid. Goiter, hyperthyroid. It doesn't mean anything to me except it is enlarged. So, what is the use of TSH? The main use of TSH is to differentiate between primary disease and secondary disease. What's the meaning of primary disease? Primary disease in the thyroid. The hypothyroid state is due to thyroid impairment. The thyroid gland is diseased itself. So if I'm going to give this gland TSH, what will happen? Nothing. Big zero. Nothing will happen. Because the primary disease in the gland. The gland tissue is destroyed by autoimmune, by antibody, whatsoever. So there is no T3, T4. Due to what? Due to disease of the gland. So I'm going to give TSH once, twice, thrice, no effect. But if we have a secondary disease due to deficiency of pituitary gland, the gland is intact, but there is no stimulation. The stimulus is not there. So, if I'm going to give TSH, there will be increased T3, T4. This is called secondary disease, not primary disease. So, TSH is used for differentiation between primary and secondary. Okay? We will know more about it when we study thyroid gland. Third, ACTH, adrenocorticotrophic hormone. ACTH, adrenocorticotrophic hormone. Can you taste the meaning of the word adrenocorticotrophic hormone? عندكم أي استطعام لها؟ What's the meaning of adrenocorticotrophic hormone? It stimulates. No. Not only that. What's the meaning of the word trophic? What is the reverse of trophy? Yes. Atrophy. Increased trophy, hypertrophy. So, if we don't have ACTH, there will be atrophy of adrenal cortex. So, from the name, we will know two things. First, it's very important for the release of the hormones, like cortisol. Second, it is not needed only for the release of hormone, but for the integrity of the gland. Without it, there will be atrophy, failure of the gland to exist. Thirdly, it's concerned only with the adrenal cortex and not adrenal medulla. So I can deduce all these informations from the name, adrenocorticotrophic hormone. Very easy. So let us see what is the benefit of ACTH in medicine. What are the therapeutic uses? First, diagnostic. What's the meaning? To differentiate between primary and secondary. Again, the deficiency is called Addison. Deficiency of adrenal gland action, adrenal cortex action, is called Addison disease. So, if we have a primary Addison, meaning what? The disease in the adrenal cortex itself. What about secondary? Hypothalamus anterior pituitary, something like that. Away from the gland. If I'm going to give ACTH and there will be increase in cortisol level, the disease is secondary. No effect, the disease is okay. I'm going to use ACTH for therapeutic reasons. What's the meaning of therapeutic reasons? I'm going to use it to stimulate the gland. If the gland is suppressed for a long period. What is the main cause of suppression of the gland for long period? Medication. What type of medication? Corticosteroid therapy. Let us understand this. I'm going to take corticosteroids daily for about 1 year. What will happen? Negative feedback. Inhibition of releasing factor and inhibition of anterior pituitary. So inhibition of ACTH. What will be the effect? Yes, impairment of the gland, decreased level of endogenous corticosteroids. So if we have a long period and we need to stimulate the gland, we must give exogenous ACTH to increase the size and vascularity and function of the adrenal cortex. What is the most important time that you need corticosteroids for? What is the most important time? Yes, stress. So, during stressful condition, if the patient, let us see this. What is the meaning of stress? Because you understand stress معناه ان حضراتكم متنرفزين او حد اتخانق معاكم النهارده الصبح. لا, stress is not like that. This is not stress. Stressful conditions like infection, stressful condition like surgery, stressful condition like 1 month of examinations. This is a stressful condition. You need your anti-stress hormones. One of the most important is corticosteroids. So, in order to stimulate the gland to release more corticosteroids, you must give ACTH during stressful conditions. And we will concentrate on that later on while we are talking about adrenal cortex. Okay? هنوضحها أحسن من كده لما ندرس الكورتيكوستيرويدز. What are other uses of ACTH? I'm going to use it to release cortisol. So, I'm going to use it instead of cortisol. بالراحة. عندك حساسية. عندك autoimmune disease. عندك أي immune suppression you need, you give cortisol. Instead of giving cortisol, you are going to give ACTH. But usually we prefer, in most of the cases, cortisol. Why? Simply because we have a lot of reasons, and we are going to discuss that in corticosteroids. But first of all, for one reason. I'm going to say one reason now. ACTH is given by injection. Every day you are going to take one injection intramuscular of ACTH. Or it's easier to take one oral tablet. So, for the patient, put yourself in instead of the patient. ما ياخد حقنية عن ما ياخد حقن. طب انت يا اخي لو كل يوم قلت لك هتترزع حقنه لمده 6 اشهر مش هتعيط؟ حط نفسك مكان الغلبان اللي جاي لك. يا ساتر، ساعات بيركبكوا السادس. ياخد حقن. طب ماشي، مسيرها تلف ترجع. اوكي. Let's see. Gonadotrophic hormones, I'm going to talk about it in the next module. Yes. Yes, there will be. There will be. It's very important. There will be. Because the very common, very, very common to use corticosteroids more than TGMT4. The uses of corticosteroids, as we will know, is by far very, very, very common. We have a lot of indications, but we have only one indication for TGMT4. So, the negative feedback and inhibition of TSH and the atrophy of the thyroid gland is not that common. Okay? Thank you for asking. انتوا سمعتوا قاعدين تتفرجوا علينا واحنا بنتكلم انجليزي. طيب. هي بتسالني يعني مش تي اس اتش ده مهم؟ ليه ما قلتلناش مثلا هيحصل اتروفي من غيرها؟ من غير تي اس اتش. فالرد بسيط ان هيحصل اتروفي بس مش فيري كومن ان انا ادي تي 3 وتي 4 بحيث اعمل انهبيشن لل تي اس اتش. يعني الكونديشن اللي بيحصل فيها التي اس اتش انهبيشن ده رير. بينما الكونديشن نتيجه الفاست ماجوريتي اوف يوزز اوف كورتيكوستيرويدز هتقابلها كتير قوي. فالكلام هنا على very common indication, very common situation. You are going to deal with it. Very common. اوكي؟ ده كانت الاجابه وده كان السؤال وساعاتكم ايه وانتوا قاعدين تتفرجوا. طيب. ما علينا. تعالوا نشوف. Let's see prolactin. What's the importance of prolactin? Prolactin is very important for the release of milk. So, we have a disease called galactorrhea. We have a disease called gynecomastia. We have a disease called pituitary adenoma. We have a disease called irregular menstruation and amenorrhea. يعني مفيش menstruation خالص. Amenorrhea. We have a disease called reduction in male of erection or impotence and infertility. We have a CNS disease called Parkinsonism, right? This is, all these diseases are caused by excessive amount of prolactin. Prolactin, if increased, there will be negative feedback inhibition on FSH and LH, gonadotrophic hormones. What's the meaning of galactorrhea? Excessive milk secretion without pregnancy or lactation. This can lead to, in the female, irregular menstruation or even amenorrhea. difficulty in conception, delayed pregnancy. In male, there will be impotence and even inhibition of sperm count, azoospermia or hypospermia due to high level of prolactin. So, if I'm going to give you a drug to inhibit prolactin, what will be this drug? Bromocriptine. You remember bromocriptine? You remember bromocriptine? It is a dopaminergic agonist, stimulating mainly D2 receptors. What is the relation of dopamine to what I'm saying? Dopamine is prolactin release inhibitory factor. So if I'm going to act like dopamine, I'm going to inhibit the release of prolactin, as dopamine will do. So, the main use of bromocriptine is to treat galactorrhea, gynecomastia, pituitary adenoma secreting such amount of prolactin, irregular menstruation or amenorrhea due to high level of prolactin, impotence and hypospermia due to high level of prolactin, Parkinsonism instead of L-DOPA. That's why we have a lot of uses for bromocriptine, by stimulating D2 receptors in pituitary and in the basal ganglia for Parkinsonism. Okay? Let us see. Yes. Yes, thank you for asking. Gyneco means females. Mastia means breast. So, enlargement of the breast in male to simulate the female. This is gynecomastia. Let's see. Posterior pituitary, we have two important hormones. What are they? Vasopressin or ADH and oxytocin. So, vasopressin or ADH. What are the difference between vasopressin and ADH? I'm going to take a blood sample from this one. This young dog. In the dog stage. He is in the dog stage. Right? DOC. Not DOG. Dog stage. Later on, there will be TOR stage. TOR stage. To be doctor. So, in this situation, in this chair, I'm going to take a blood sample. What I'm going to find? Vasopressin or ADH? Or both? They are the same. But they have two names. Why? Two actions. What I'm asking about, what are the actions now in this dog? ADH. Can I find action in one of you, in any one of you? Vasopressin action. Pray to God, you will never see this day. Okay? Pray to God, you will never see this day. Why? It is vasopressin during irreversible stage of shock. Irreversible stage of shock. Released from hypothalamus to cause massive and severe and generalized vasoconstriction in all organs, including the vital organs. Dalma. هيضلم الدنيا كلها كرسي في الكلوب ويلا بينا ما حدش شايف حاجه. ده الفازوبريسين. فطول ما هو طالع بكميات صغيره مينيمال اماونتس اتس اونلي ADH. طب ازاي ربنا يعمل كده؟ يعني نظبطها كده ازاي؟ Two types of receptors, V1 and V2. V1 and V2. Where is V1? Where is the receptors of V1? Where are they? Blood vessels, smooth muscles. V2, kidney. For anti-diuretic hormone action. For water reabsorption. In distal convoluted tubules and collecting ducts. To maintain the osmolarity of your urine. Anti-diuretic hormone. To retain water. What is the big difference between V2 and V1? I want one word. One word on. Thank you. Sensitivity. The V2 receptors are very sensitive. They can be stimulated by minute amounts of ADH. But V1 are less, by far less sensitive. They need huge amount to be stimulated. That's why they don't act usually unless massive amounts are released. Right? So, why this bloody introduction to the subject? Because I'm not going to use vasopressin for systemic vasoconstriction. I could say it and save 5 minutes. I could say it. I'm not going to use, and you all, as usual, accept it. Accept it. You are an obedient student, right? Thank you. Taking the information. طائفة كل واشكر. حضراتكم هتشكروا. يا سلام. وجاي يقول لنا كمان شكرا. No. We must know the background in order not to understand whatsoever. But the direct information will pass in front of you and you are going to forget all about it after 1 hour. وكان بيقول ايه؟ عادي يعني. ايه ده؟ الكتاب ده اتفتح. ده لولا ان انا كاتب بايدي وعارف خطي الصفحه دي اتذاكرت. هي اتذاكرت بس من النوع اللي بيطير كده. ما دخلتش. ما فكرتش فيها. ما سالتش، ما خدتش وديت معاه. اللي بتاخد وتدي معاها ما تنساهاش. انت فاكر حاجات مواقف حصلت لك من اولى KG 1 وفي حاجات في الثانويه العامه. ايه ده؟ احنا درسنا ميكانيكا ولا شفناها. لو جبت لك النهارده ضرب، جدول ضرب 8 في 12 بكام؟ شغل على كده صح؟ جدع. Okay, let us see. What are the uses of ADH? 1. Deficiency of ADH is called. Deficiency of ADH is called. يعني هقعد ادور على العين التايه. Deficiency of ADH is called. No. She said diabetes insipidus and said 3 no. Pituitary diabetes insipidus. Be specific. Deficiency of ADH is called pituitary diabetes insipidus because we will have another type of diabetes insipidus where the defect is present inside the kidney, so it's called nephrogenic diabetes insipidus. We have a lot of ADH but no response. So the main use of ADH is not diabetes insipidus and full stop. No. It's what? pituitary diabetes insipidus. Second, I'm going to use it for vasoconstriction action. No, I said there will be no systemic. So, I'm going to use it to produce vasoconstriction localized, in a localized area. So, I'm going to use endoscope to inject it inside the esophagus, where the varicose veins are. It's called esophageal varices, bleeding esophageal varices, hypertrophied esophageal varices. In order to cause vasoconstriction in these vessels only, no systemic vasoconstriction. I'm going to combine vasopressin with local anesthetic to produce localized vasoconstriction here, to prolong the duration of action, to prevent the systemic absorption of the local anesthetic, to prolong its duration, to reduce bleeding, and so on. In this area only. So I'm going to depend on it as a vasoconstrictor on a localized purpose, not systemic. Another action of vasopressin, it stimulates the release of anti-hemophilic globulin from the liver and von Willebrand factor. Sorry. Von Willebrand factor, platelet factor 4, clotting factor 8, anti-hemophilic globulin. Stimulates the release of these two factors for treatment of bleeding tendency called hemophilia. So I'm going to use it not for a systemic purpose vasoconstriction. The only systemic reasons are pituitary diabetes insipidus and hemophilia. Vasoconstrictor localized for two reasons. I'm going to hear them from you. One, with local anesthetic. Second, esophageal varices. What are the preparation of vasopressin? What are the preparations of vasopressin? The preparations of vasopressin are: one, patricine. This is an old preparation. Patricine. It's given by IM, intramuscular injection. This is out of use, not used, not preferred, because it is injected. Now we have a synthetic analog called desmopressin. This is the drug of choice in treatment of pituitary diabetes insipidus. Pituitary diabetes insipidus. This is the drug of choice. Why? It can be given by injection, but more important, it is given by nasal spray and recently orally. So this is preferred in chronic stage, chronic uses, chronic cases. It's very easy to give a nasal spray to be absorbed from the nasal mucosa. It's very easy to use it oral for chronic reasons. Yes? Oh, she made a very bad mistake. She told me it can cause vasoconstriction. At what dose it's going to take? هيتكسر. Yes. نفس السؤال؟ لا ده اندوسكوب. ده لوكال، انا بديه بالاندوسكوب مش هيروح في حته، انا بديه لوكال. طيب يلا بينا على الهرمون الثاني اللي اسمه حضراتكم اوكسيتوسين. ايه الهرمون الثاني؟ اوكسيتوسين. بيعمل ايه الاوكسيتوسين؟ بيعمل contractions في حتتين. Two sides for contractions. First is rhythmic contractions of the uterus. Say it, rhythmic contraction of the uterus. What is the difference between contractions and rhythmic contractions? Rhythmic contractions means, in this case, two things. One, it is contraction followed by relaxation. Rhythmic. Second, it's contraction of the body, relaxation of the cervix. So a lot of difference between saying contractions and rhythmic contractions. Second, so it is the drug of choice for induction of labor, abortion. It can be used also, but not the drug of choice, for postpartum hemorrhage. Why it is not the drug of choice? Because we have another drug that can cause the tonic contractions, sustained contraction of the uterus. What is this drug? Right, methyl ergometrine. Methyl ergometrine is the drug of choice for postpartum hemorrhage. Why? Is going to cause sustained contractions. I don't need in postpartum hemorrhage rhythmic contraction. I need sustained tonic contraction to close the blood vessels, placental blood vessels. It can be used also, this oxytocin, it can be used to help in milk ejection, impairment of milk ejection, milk congestion, by contraction of myoepithelial cells surrounding the milk acynon, to help to release this congested milk. So the uses in two organs, because it can cause contractions of two muscles, the uterine muscles and myoepithelial cells covering the breast acynon. It can be given as oxytocin IM or IV infusion. It can be given as nasal spray, second hormone as nasal spray. So we took today two hormones taken by nasal spray. The first is desmopressin, the second is oxytocin. What about hypothyroidism? I'm going to treat hypothyroidism. What are the cases of hypothyroidism? One, cretinism. Right? Cretinism. Second, myxedema. Third, myxedema coma. These are three titles under hypothyroidism. What is the difference between cretinism and myxedema? The age. This is adult hypothyroidism. This is childhood and even infantile period after 6 months. And if I'm going to diagnose and treat this case, he will be or she will be completely normal individual. If I'm going to diagnose this after 6 months, there will be permanent mental and motor retardation. That's why nowadays, every child or every infant, we must estimate the level of T3, T4, TSH during after birth, immediately after birth. to diagnose the case. To start treatment as early as possible. Before complete demyelination of the nerves. Complete destruction of the brain tissue. So, what about myxedema coma? What's the meaning of myxedema coma? What is the meaning of myxedema coma? Patient in a coma. So what? رقص أو ترقص. Okay. نورت المحكمة. What's the meaning of myxedema coma? يعني أنا لا بسأله، أنا ماشي في الشارع كده وإذ فجأة وقعت عليا طوبة فجالي ميكسيديما كوما. طب حلو، طب مظبوط، طب نعم. What is myxedema coma? أجيب سيفير كوما وما فيش مخ. اوكي. وكوزد باي ميكسيديما. كل ده جميل قوي. بس هو مش ده السؤال. What is the question? What I'm talking about. Myxedema coma means acute on top of chronic. He is not a normal subject. He is myxedema from the start, not treated well, and subjected to stressful conditions, like infection, like surgery, like whatsoever. And so, there will be marked need for T3 That's why acute deficiency occurs. That's why it is changed, the case is changed from chronic condition into acute insult. So, I must treat it now. You took the meaning of myxedema coma now? Okay. Let us see. We have T3 and T4. First, what are the name of T3? Triiodothyronine. What's the name of T4? Tetraiodothyronine or thyroxine. Right. The binding of T3 and T4, the binding of T3 to plasma protein is 99.6%, while T4 is 99.96. So, by simple mathematical process, subtraction from 100%, the free part is 0.4%. The free part is 0.04%. What is the importance of this data? What is the importance of this data? Why to bother you? Why giving all this mathematical information? 99.9.96.6 what the hell? Right? What can you understand as a physician from this information? Sorry? Thank you. The T-half here is 2 days. The T-half here is 7 days. Because the binding is more. And this is a rule. The more the bound, the more the duration. This is the first information to deduce from this knowledge. What else? What else? To understand. Yes. This is by far faster in onset because the free is more. But you are not thinking right till now. This is a very obvious information for all drugs. You are talking about all drugs. No. I am talking about a very important figure. It is over 99.6. 99.6. I'm not talking about 90 or 80 or 60%. I'm talking about 99.6. Why God you create this? What? Again? This is a very important reservoir. This is a very important storage area to guard against myxedema and myxedema coma. What is the function of T3 and T4? What is the importance of T3 and T4? Can you tell me? Can I have one function, please? One function. One function. Basal metabolic rate. What is the meaning of basal metabolic rate? Blah, 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 blah. Blah, 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 blah. بلا 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 هتغطى ببطانية هقعد في تكييف. The cell stays alive. Right? Basal metabolic rate means the cell stays alive. Can you live without a basal metabolic rate? This is the baseline. So, the thyroid hormones are very important to keep you alive. Simply. Right? So, our gut creates protection for us. Two protection for thyroid. We have two sites for the storage. Inside the thyroid gland, it's called thyroglobulin, and the second store is the excessive plasma protein bound area. When you finish this, you are going to take from the second reservoir, which is plasma protein. Second, let us see the site of action of T3 and T4. What are the sites of action of T3 and T4? Every cell, where? And by what mechanism? Where is the receptor? Inside the nucleus. So, they are lipid soluble. They are going to traverse the cell wall and the nuclear and go to the DNA and produce transcription, messenger RNA, going to the ribosomes, producing protein. This takes about 6 hours. What is the meaning of this? 6 hours. What is the meaning of this? It's a delayed onset of action. What is the meaning of this? As a physician reading, it has a delayed action after 6 hours. A delayed action after 6 hours. They are not active unless 6 hours lasts. Sorry? In a coma, I'm not going to anticipate the actions unless 6 hours are gone. Right? 6 hours are gone. Right? If I don't know this information, what will happen? One, the patient will die. Right? Second, the patient will die. He is going to die from 2 reasons. Very common reasons. First, there will be no actions. And what are you going to do? The drug is not working. Or the dose is not sufficient. Come on! Give it! More! bakshish. Go! Another dose, third dose. Right? Right? No response because the action is not there. And if the patient stays alive by a miracle, he's going to die again. Why? Why? He's going to die. But not from the disease, but from the overdose. You change it, a freezer into oven. You change it, the hypothyroid, severe hypothyroid into hyperthyroid. You change it, a weak heart beating at 50 max into a heart beating at 200 at least. So you are changing a severe bradycardia and heart block into a severe tachycardia. The heart will go banana. And thanks to you, because you don't know a simple information. It acts after 6 hours. Okay? So it's very important, very crucial for our work. The pharmacology is our tools. How can't we know it? How? It's our tools. You are going to treat with histology, with biochemistry. Okay? They are very important subjects, of course. But this is not your tools. The direct tool is pharmacology. You must know what are you giving to your patient. We have a lot to do. But we must know our weapons. This is your weapon. عندكم حاجة بعد كده؟ طيب الساعة 2 أنا بس هاخد ربع ساعة أكمل فيها الموضوع بس بعد إذنكم. اللي عنده حاجة يستأذن بس عشان أكمل الموضوع. So we have now 3 uses. We have now 2 types of preparations we must talk about it. One is T4, 2 T4, 3 T3, 4 T3, and T4. So we have 4 preparations for thyroid. The first is T4. It's called L-thyroxine tablet. L-thyroxine tablet. L stands for what? Levothyroxine. L-thyroxine tablet. Levothyroxine is given as a tablet. And this is by far more common than others. They are given for treatment of the first 2 indications, cretinism and myxedema. If you are going to tell me this is a tablet, and you said to us, I'm going to start the treatment before the age of 6 months. How can child or infant in this age will take this tablet? I'm going to crush it, yes. I'm going to tell the mother to crush it and give to him. And very important to estimate the dose. And must take all the crushed amount. We have levothyroxine sodium as IV infusion. What is the use of the second preparation, levothyroxine sodium? In myxedema coma. We have a preparation called T3, liothyronine. Liothyronine. What is liothyronine? It's given by IV infusion or by stomach tube. What is stomach tube? Nasogastric tube, yes. What is the meaning of nasogastric tube, stomach tube? I'm not Translating. Yes. We have here stomach tube administration. Why? No, I mean T4. We cannot give T4 by stomach tube. Why? But we can give T3 by stomach tube. Why? Absorption. If you compare the absorption of T3, the absorption of T3 is 95%. The absorption of T4 is 65%. So we can depend on T3 as a stomach tube to be absorbed from the stomach, from the GIT. So we have 3 preparations to treat myxedema cone. We have IV infusion of T4, IV infusion of T3, and stomach tube of T3, lithoaramine. When to use each one of them? All of them will be used in one reason only. Myxedema cone, full stop. When to use? What حسب الله؟ حسب الله إيه؟ level؟ قربتي؟ بس أنا عايز أوضح. time؟ turn. Let us ask you a question. What is the best to achieve the goal of the 3? What is the best to achieve the goal? IV what? We have 2 IVs. Sorry? Yes, IV T3 is the best to achieve. Why bother you by other preparations? Why? Why bothering you by other preparations? Why? We have a very rapid onset, so I'm going to tell you, I am going to use T3, IV infusion, lithoaramine, thank you, go to home. Why? We have a preparation called T4 IV infusion. We have another T3 giving it by stomach tube. Why to bother you? I'm going to say half of the answer and you must complete the rest. According to the severity of the case. According to severity of the case. Severe, IV infusion of T3. Moderate, IV infusion of T4. Less, mild, stomach tube T3. Why? Why we are so afraid? What is the main fear? To change the hypothyroid into hyperthyroid. Please remember this. We better undertreat than overtreat. We better undertreat in any case of hypothyroidism. It's better to undertreat than to overtreat. The undertreat, the patient is still with us. He lives, so we can adjust the dose later on. Overtreat, he may die. And so the patient will not be in our world. So we cannot justify or rectify the problem. Right? Remember that. You can withstand hyperthyroid because you are normal. I can increase your heart rate from 80, 90 to 200. You will not die. But if it is less than 50 and you change it to over 200, he's going to die from arrhythmia. That's why we have multiple routes of administration. Another preparation which is called Liotrex. What is Liotrex? The more physiological form. God creates a mixture. This is a mixture between T3 and T4. The major amount is T3, is T4, T4, 4 times T4, 1 time T3. The more potent, little amounts. The less potent, larger amount. Litrix. From this preparation, I can deduce 2 things. If I'm going to think it over. First, we don't have an oral tablet of T3 solo. Why? Why we don't have T3 as a tablet solo? Solo? Because rapid onset, short duration, more potent, so I am afraid of changing the case from 2. Right? If I'm going to use a preparation containing T3, there will be a mixture of T3 and T4. What is the place for using Litrix? What is the main use of using Litrix? The combination. What is the main use? لا انا بتريق عليكم مش بجاوب. Failure of response to T4 alone. If we try T4 first, and this is very common to use in any hyperthyroid state, I'm going to give the patient T4 first. Tablet, L-troxin, levothyroxine, tablet. And let us see what will happen. After time of increasing the dose, there will be no effect. So I'm going to combine T3 and T4. Okay? عشان I have a more potent T3. No, it can work. And sometimes it's said that T4 is changed inside the body into, or inside the cell into T3. Yes? Shorter. T-half is 2 days. It's not that short. Right? Yes?
Doctor, and T3 is more potent than max T3 and T4?
Yes. If I'm going to take a full amount of T3 and full amount, exact amount of mixture, there will be more potency of T3. Right? Let us see. I have a side effect of the preparations. I can say all the side effects in one word. What are the side effects in one word? Hyperthyroid. Right. If I am going to give you high dose of the thyroid preparation, the result will be a hyperthyroid state. Tremors, restlessness, irritability, insomnia, tachycardia, angina, arrhythmia, hypertension, weight loss, heat intolerance, all the manifestations except 2. No exophthalmos, no bite. Why? No. Never. After 10 years of therapy, never. Yes. Goiter is due to his TSH, and TCU-T4 will inhibit TSH. Never because goiter. Second, exophthalmos is an autoimmune disease, long-acting thyroid stimulator, retroorbital edema, another pathology away from T3 and T4. So T3 and T4 can never do that. Right? I can have all the side effects except exophthalmos and goiter. Again, if you give your patient T4, you already gave your patient T4, and side effect will happen. What are you going to do? You gave your patient T4 tablet and you examine the patient, or he will come to you complaining of tachycardia, anginal attacks, arrhythmia, tremors. What are you going to do? Stop or reduce the dose? Or combination? Combination of what? كده انت رايحه ناحيه الاكثر. Sorry? I am going to treat the symptom if I could, yes. But I am going to do what? I am giving the patient T4 preparation. Stop. Okay. ما تاخدش النهارده وبكره. ما تاخدش امبارح. ما تاخدش لمده شهر. Yes, why 7 days to stop? Why? To reduce the plasma level to its half. This is the importance of knowing T half. I must be on the safe side. He may complain of some hypothyroid. Okay, it is better to than overtreat. Right? So I'm going to stop the medication for 7 days, 1 week. And then I'm going to restart by a lower dose than the already given before. Okay? What's yes?
The combination or upward day?
Combination the same. اسبوع برضه. ليه؟ 87 days. This is the delayed form, right? So after 7 days there will be no of T3. 3 T halves for T3. Okay? I'm going to tell you, I have a patient with high level of T3 and T4. By examination, what I'm going to do, examine the patient first, estimate the T3 and T4, what I'm going to do. What is the main item to deal with? Yes, he is taking T3, T4, or T4 only. He is taking medication for hypothyroidism. I am saying to you that you must depend on both the level of hormone and the clinical condition of the patient. Don't forget either one of them. The patient is very important. So you must tell him to go and check in the lab, and you must examine the heart rate, the blood pressure, and so on, the manifestations you are going to ask about. Okay? كمل الاثنين الجاي ان شاء الله.